Thank you, Dr. Young-Fedok. I don't think I've ever been described as a massive whack doctor, but I'll take it. So I'm going to talk about our experience with HIPEC here at Mayo. And I would consider cytoreductive surgery and HIPEC kind of like the last frontier for enhanced recovery. And when I started to think about doing this, inspired again by some of the work that you've heard about today, I went to PubMed, I went to Google, Google Scholar, and there was really nothing out there on anyone who'd even tried to implement this. So unlike the red and green and system you saw, I had to do none of that because the only person doing this was me. So I made up my own rules, and I'm going to talk to you a little bit about what they were, and then we implemented it, and then we actually have some data to share with you today as well. So for those of you who are not familiar with what cytoreductive surgery and HIPEC is, it is a surgical treatment option for advanced peritoneal malignancy. And traditionally, this has been associated with very long operative times. It's not uncommon for us to be there in the operating room for 10 hours, doing multiple resections, and then adding intraoperative chemotherapy on top of that. And traditionally, HIPEC is a scary procedure for patients because the morbidity and mortality associated with all this surgery and then chemotherapy on top of that is quite high. These patients also spend a lot of time in the hospital. The median stay traditionally is about 16 to 19 days, and across the pond, it's even higher. So this is, kind of like ripe for the picking for enhanced recovery. So when we set out to do this, the objectives were simple: to try and take some of the ERAS principles and translate them to this world, and to really try and reduce that postoperative morbidity, mortality, as well as the length of stay that I showed you. We started implementing this around 2016. Our HIPEC program here at Mayo, and we were the first site to do this out of all three Mayos, was in 2011. So we built up our early experience from 2011 to 2016 with the quote-unquote old way, and then implemented this in early 2016, and then following that, just kept it pretty consistent for the rest of our patients up until today. So what did we do? This table kind of outlines how it was done, and then